Okay, my name is Debbie Charlton, and I'm with the National Scleroderma Foundation, the Texas Bluebonnet chapter. We are very fortunate and blessed to have Dr. Khorsandi with us today. He will be our speaker on hand and wound care with scleroderma. A couple little hints for today's webinar. We have attendees are muted and cameras are turned off. Ask questions for the physician presenter in the chat section of your control panel. Our co-host will select the most frequent questions for Dr. Mark Khorsandi at the end of the presentation. Today's hosts are myself, facilitator Debbie Charlton, San Antonio Support Group, co-host Lily Weatherspoon, Dallas Support Group Leader, and co-host Renee Berlender, Texas Advisory Chair. Okay, Dr. Khorsandi graduated from Nova Southeastern University Osteopathic Medical School in 2005. He completed hand surgery fellowship at Albert Einstein University, Beth Israel Center. His mentor was Dr. Charles Malone, who recently retired. Dr. Malone had written several articles on management of scleroderma related to the hand. Their clinic had many scleroderma patients coming from the greater New York area and beyond. Dr. Khorsandi is double board certified in general hand surgery. He has continued to work that he did with Dr. Malone in the Houston area and has treated many patients with hand-related conditions caused by scleroderma, including myself. He has worked closely with the scleroderma community, the Scleroderma Foundation, and many esteemed and respected doctors in Houston, such as Dr. Mays and Dr. Asasi. In 2013, he was awarded the top doctor in hand surgery. His specialty, treating patients with minimally invasive techniques. Dr. Khorsandi is a member of the National Scleroderma Bluebonnet Chapter Medical Advisory Board, along with Dr. Mays and Dr. Asasi. Dr. Khorsandi, we'd like to welcome you again and thank you for your time. And at this time, if you would like, you can start your presentation. And then after your presentation, we have Renee and Lily, our co-hosts, that will be reading questions to you that will be coming through our chat. And if you'd be so kind to answer those questions, that would be great. And any questions that we don't have time for today, Dr. Khorsandi, we can get those to you at a later date, and then email those back to our attendees from today. Okay? All right, Dr. Khorsandi, take it over.
Well, thank you very much. It's always a pleasure to speak before this community. I love doing these talks, and I hope you enjoy this. The power of Zoom is wonderful because I'm sitting in my office freezing cold in Houston, Texas as it rains. And if y'all can hear me clearly, that's great. I love giving these talks because I feel like we make a big difference in a lot of patients' lives. And I know that sometimes even finding the right hand doctor is not always easy, especially if someone wants to deal with patients with scleroderma. And over the years, I fondly and love taking care of the patients that have scleroderma because I know I can help them out as best as I can. So I want to spend some time, talking about basic stuff, a little bit of advanced stuff, new stuff, old stuff, and just give you all kind of a kind of a broad spectrum idea of what I do and how I may help you should you need me in the future. So we'll talk about wounds, open wounds, dry wounds, how to manage your hands on a daily basis, medical and surgical options, and newer things such as Botox, stem cells. One of the things that we always have a concern for are ulcers. And the things that we look at are the size, the location, the involvement of other structures that may affect it, infections that may be arising from that, the ability for these ulcers to heal themselves, and finding out if there's any causes or reasons that these ulcers aren't healing, such as poor blood supply, the angulation where they are on the bone. Is it too much pressure? The skin too tight? Things like that. And so this is just typical fingertip ulcer that you may see. Looks kind of, dry, but underneath that, there was probably bone and pressure on there, and poor blood supply to the finger. We typically see a lot of these other ulcers on the backs of the knuckles here as the fingers contract, and they can be very problematic. They can get infected. They never heal. They can be painful. All sorts of problems, and plus, nobody really wants to have to deal with open wounds and bandages all the time. So again, we look for, what's causing the pain? Is underneath that soft tissue or the skin? Is there exposed bone, tendon, nerves? Is there an infection? Osteomyelitis just refers to that infection moving into the bone, and so that is always a possibility. I'm less concerned about the way it looks, but that is always a concern for patients, and the limited ability to use that finger due to the ulcer, whether it's causing any of the above. So infections from an open wound, you can look at them as a superficial type, a deep one, or the bone. And we'll try to treat those with antibiotics if we can. There's sometimes a need for IV antibiotics, sometimes a need to wash them out or make a cut, drain the pus, or quite often what happens is you may have to do a combination of all that and some wound care to get these wounds to heal. And these wounds can appear anywhere. On the nail folds are very common. Tips of the fingers again. Let's see. Okay. And then the real question is, how long does a wound take to heal? In a hand that has normal blood supply, maybe 7 to 10 days, as long as we address any underlying causes. But wounds that are open tend to become more susceptible to all the things we just discussed: infection, pain, chronic issues. And then then there's always the cosmetic appearance and concern that you might spread some of that infection to other areas. So, you can see the wounds here on the back of the knuckles. They're open, chronic infection of that finger. So, a lot of patients will experience more of these dry ulcers as well. So, these, I'm not so concerned as long as they're not causing any of the problems that we just discussed. Well, then what do we do daily to prevent some of that stuff? Hand washing, keeping them warm, avoiding pressure points on known spots that may ulcer. So also with wound prevention, helping your blood pressure, your systemic blood pressure is always helpful, because with the blood pressure staying up, you're going to get more blood to the extremities, and that's so important, especially when we already know, and we'll talk a little bit more later on, there is diminished blood flow to the hands. And so there's different types of blood pressure medicines. They're categorized as calcium channel blockers. Those are the most common. Then you have other things that we may use, such as sildenafil. You can use topical creams, and then really a good daily wound care ritual. And while I call it a ritual, I think it's everyone needs to find the thing that works for them. I don't think there's any specific routine that's perfect, but if you find a routine that works for you, you should stick with it. Especially, I think it suits a lot of patients in the long term, and keep your hands warm. And here's our host, who's going to tell us more about her daily wound ritual. So here we go.
No, we can't hear. What I'm doing here, everyone, is I soak my fingers in a bowl with this antiseptic, and this is the tubular gauze that I use to wrap my fingers. This antiseptic is a pain-free antibacterial wash that helps flush out the ulcers if they're ulcerating and there's any discharge. This is the zero form that Dr. Khorsandi prescribes to me, that it's like a gauze with a Vaseline substance on it that I put over the ulcer so that it doesn't stick to the scab when it starts to heal. And this is very instrumental, that we try to keep the scabs and we don't peel them off every time we cleanse our ulcer, because that scab is what heals it. This is the gauze that I use to clean them and kind of sort out any oozing, and the Coban tape that I use to wrap around the tubular gauze. And I always have scissors on hand. And that's the tubular gauze that's cut, that's pre-cut, so it's ready to use. And I twist it when I put it on the finger, so it covers the tip of the finger as well. And that is the device that you get at Walmart or Walgreens. It's like a little tip you put the tubular gauze in there, and you pull it and you twist it, then you bring it back down, and it totally covers the whole finger. And so here I am soaking my fingers, and I also have a terry cloth towel that I use to kind of dot my hands and dry them. You want to make sure, it's very important that they dry and you don't wrap them while they're still damp. And I know Dr. Khorsandi has warned me not to get the water too hot. I get it hot enough for me to where it helps drain the ulcer, to get all the pus and et cetera out. But again, every patient is different. And this is a procedure that I use to cleanse my wounds. And it's very important that we keep them clean. And then once they start healing, where the flesh is not so raw, I will sleep with them to let them air out. That's very important as well. This is just a procedure, like Dr. Khorsandi mentioned, that you got to get your a procedure going, a routine going, to help those ulcers heal. One thing important, you don't ever want to put the Coban wrap on top of the ulcer. We don't want to put any pressure to aggravate that ulcer in any way. So this is just a routine that I do. There's a splint that you can see right there on the side that I also utilize to protect my ulcers, so that I don't bang them when I'm working around the house or things like that. So there's a lot of little things that we can share with each other that we do. But again, you want to check with your doctor on that part. So thank you, Dr. Khorsandi, for sharing this with everybody. I think maintenance is key on our ulcers. So that's what this video is about.
Yeah, that was great. And that's what I'm talking about a ritual. You know, I do like warm water over cold water, obviously. And, you know, like Debbie said, don't put the Coban too tight, because that could also cause, you know, limited blood flow. So I always like the zero form, because it is got some Vaseline and antimicrobial properties with it. But for the most part, you know, maintenance is a good thing for these wounds, and over time, that's how you get them to heal. You know, if you have good blood supply. So these are just some pictures of, you know, wounds that are healing over time, and you could see, you know, we can get them to look like this, and there's no pain. I'm happy. So Debbie does a great job, and there's so much out there in terms of wound care products. I don't endorse any one over the other. I think just find things that work for you, that make sense. And so question is how do all these ulcers form, and what can I do also to further prevent them? So I keep mentioning blood supply is tantamount to wound healing, and unfortunately, when you have scleroderma, this is diminished significantly. This is on the right is what we call an angiogram, and when you see the block going all the way down to the fingertips, that's good. When you see it lighter, that means that blood vessel is not getting enough blood. And in our hands, we have two blood vessels on each side of the finger, on the palmar side, And then we have what we call collateral blood circulation, which means even if these blood vessels are out or diminished, blood will get there through very, very small channels that you can't see. One of the things we want to always make sure is we maintain that good flow. And those fingers would be the ones, if you did get an ulcer, would heal way faster. If you look at the one over here, it almost cuts off right there, and that's going to be a problematic finger. Okay, so just a little bit of visual. Lately, something new that I've been using is one of our interventional vascular guys here in town has been able to stent these and help us increase blood flow without the need of major surgery. And so if you can see, there's diminished blood flow, almost a point of compression right here. And when he goes, he puts a little tiny balloon through this little vessel here. And you can see now that there's more flow to that arch that supplies to the fingers. Now, is this a home run? No, but we're doing the best we can with what we got. And I have used him quite a bit to help scleroderma patients when we're desperate. And this is a good breakthrough. And I hope that he continues to have great results. We've had several good saves on patients that were concerned about their fingers and losing them. And just by a minor interventional procedure, we're able to increase some blood flow, which was huge for certain patients. And here's another one. You can see the typical ulcer at the finger. You can see where it almost stops the blood flow. And then at this point here, there's a little bit more blood flow afterwards, which is great. Not, like I said, not a home run, but hey, if we can get a little bit into that finger, that might be the difference of that ulcer healing. There have been times where we get fingers that look like this, black, necrotic, and at risk for digital amputation. But there have been circumstances where we can get those wounds to heal with good wound healing and some newer things that I'll talk about later on with biological tissue that we could apply. And this is a save right here just by wound care and biological tissue. This did not have interventional revascularization. I just want to touch upon what the Mnemonic Crest, because it's a good way to see some of the manifestations I see in the hand practice. I just stole the trademark. Hope I don't get in trouble for that. Well, the C is for calcinosis. The R is Raynaud's phenomenon. E has nothing to do with the hands, esophageal dysmotility. The S would be the sclerodactyly or the contractures, and the telangiectasias is the T. So 4 out of 5 of those are hand related. They can manifest elsewhere, but as far as for me, these are very common. And the telangiectasias are the ones that I don't treat because there's nothing to really do for them. So calcinosis, a big problem in some subsets of patients where you get these large calcium deposits, and they're never in good places. They're either at tips, at joints, over nerves. Sometimes they tend to be the more superficial ones are very chalky. The more mature, deeper ones into the tissue against the bone are like cement, and they can be very problematic for patients. Pain, range of motion, everything, numbness. They could be, well defined at the tufts, or sometimes very extensive. It's weird, but I don't understand why. But when patients do get it, it typically doesn't affect all the fingers of the hand. It's certain fingers, and when we debulk it or take some of it out, it usually comes back to the same fingers if it's going to come back. And I just yet to figure out why, but that's something I've noticed over the years. This is just a picture of someone who's undergoing a Raynaud's episode, and you can see the difference between the pink fingers and the white fingers. And so these fingers are the digital blood vessels are undergoing spasm or have diminished temporary flow. This is a picture of someone with sclerodactyly, and you can see the contractions of the joints of all these fingers. So, and then the 10-line jictasias, like I said, I don't often treat these. There's really nothing to do. Doesn't really bother patients. They're just there. So here's some more telangiectasias. You can find them anywhere. Okay, and then just common locations of hand ulcers. If I'm repeating myself, I'm sorry, I'm getting old. Uh, the common places we see them are fingertips, over the knuckles, the PIP joints, and around the nails. So PIP contractions are the proximal to phalangeal joint, the little knuckles. These become problematic because they can cause the ulcers right over the back of the knuckle when you start getting a contracture. Also, it affects function when it starts, flexing past a certain point. You really can't grasp objects or anything. So a lot of times I'll recommend a fusion so that we will take the bones and reposition them uh, in a more functional level at like a 30-degree angle. So you go from a 90 to 30. So it serves two purposes in doing that. One, if you do have an ulcer on the back of the knuckle, taking it out of that position will reduce the chance of an ulcer forming and heal the one that you got there. Second, again, it's going to give you a better opportunity to grasp things. With a fusion, you do lose motion in that joint, but you pretty much have no motion in that joint to begin with. So, it's really not that big of a concern for most patients. Here on the distal aspect of the finger, you can see another very contracted finger. It's almost flexed to 90 degrees, and then again, causing potential ulcers. And so if you can take the finger and put it at a better angle, that's what the middle picture show, it will help with function and also, um, deal with other issues. So I talked about blood pressure medical conditions that may make these ulcers worse. And, the biggest thing is blood pressure and flow to the hand. And, scleroderma patients are always hypotensive or very close to it. You rarely see someone that has high blood pressure. So managing the blood pressure as far as from a hand point of view is helpful if there's no contraindication or increasing blood flow to the periphery. So there's ways that we can do some of that surgically, and that's called a sympathectomy, and I'll talk about that in a minute. So about the calcium channel blockers. There's many different ones. Those are on the left, and then there's other blood pressure medicine, and then there's other medications like Trentol, which will enhance blood flow. There's ones that will relax blood vessels and inhibit platelet aggregation. About Viagra and other medicines like it. And then ACE inhibitors may help reduce some edema, swelling, and increase blood flow. And then there's, other medicines out there that may help. And I'll leave those up to the medical doctors to talk more about them specifically and how they can help you. And there is some literature out there about Botox and ulcer reduction. Talk about that a little bit later. But just keep in mind that all drugs have side effects that could be expensive. They don't always work the way they're supposed to. I find that the generics are never as good as some of the brands, and there may be drug-to-drug interactions with some of them. So you have to consider whether or not the benefits outweigh taking them. And oftentimes we'll do some off-label usage of these drugs, so it's not we're using it, but it was never intended to be used that way. I have a couple of simple rules for your hands. Just keep some mittens or warmers around. Um, Avoid rapid temperature changes. Always be prepared. Have a little purse or a satchel and carry whatever you need for your hands. If y'all in Texas, I might be preaching to the choir here, but live in warmer climates and watch out for the AC, supermarkets, frozen food sections, things like that. If you need to, you could preheat your car. They have heated steering wheels now, all sorts of gizmos. Try to keep your body warm, layers, sweaters, things like that. Um, Try not to stress out too much if you can, because sometimes the sympathetic nervous system can be affected, which could trigger like a Raynaud's event. So just be calm as much as you can. Don't let your significant other drive you too crazy, and try not to hold cold drinks for too long, and be careful with cold water in the house and the refrigerator, all that. So we talked about a lot of the different wound cares, cleansers, topicals, prescription medicine, topical antibiotics. One thing is, if you do see an infection, brewing, I always love this: the solution to the pollution is dilution. I like washing out wounds whenever possible, because the water can weaken bacteria, soaking them in water. Topical antibiotics, I tend to shy away from them because I feel like there's an infection brewing and you throw on topicals. It may work, but you're also trapping bacteria that wants to leave. So I usually opt for more like washing them out and then clean bandages and trying to change them once or twice a day over just applying topical antibiotics. Now, some people may agree, some people may disagree with me. But that's kind of what I prefer. And just be careful of the type of cleansers you use. If you have open wounds, like something like iodine would be very caustic. So you may not want to be putting iodine into an open wound, and some of these will burn. Good old soap and water or sterile saline is one of my preferred things. And like I said, soaking and whirlpools are always helpful. There are different types of creams, and they have different properties in them. Emollient creams help with moisturizer, and those are good for maintenance. And the hydroxyethylurea types of products like Eucerin will make the skin happier because they got a little bit of acidity to them. Vaseline can be a good moisturizer and cheap. Same with Aquaphor. If you have severe dry, itchy skin, you can get some of this Peroxide, sauna sensitive, and tacrolimus ointment can be used for fragile dry skin as well. Just like I said, there's so much out there in wound care that for everyday maintenance. But just the things that you want to try to avoid are the A's: vitamin A, retin A, anything with retinol, anything with alpha hydroxyl acid. Why? Because it's going to stimulate collagen. That's something you don't want going on in someone with scleroderma. I don't know how to avoid the next one: sodium lauryl and lauryl sulfate. It's an irritant, but it's in almost every type of soap or anything. It's very hard to find products that don't have it, but they potentially could be irritants. So if you're having issues with that, check the label and see if you can find products without it. It may help. Again, talked a lot about the basic wound cares. Debbie's video and instruction was very helpful. I like the Xeroform as mentioned, or Adaptic. And I just touched upon some of these solutions. already, so I won't go into them again. Covering wounds, I like non-adherent layers, so Doppik or Zeriform. Always keep it loose, splint if needed, and you could pack wounds if they're deep, but quite often in the hand or fingers, you're not going to have too deep of a wound to worry about. Are there other treatments? Yes, we can do hyperbaric oxygens. Will create more oxygen tissue tension to the wound. It's, if you have a hyperbaric chamber locally, it's helpful if you can get a doctor to prescribe it. But you have to go multiple sessions. Wound vacs, sometimes I'll use, but not often, but they can be helpful in helping get a wound to close. And that's basically like a suction, a foam bandage over some tegaderm that sucks. And that tension can sometimes help close wounds. There's some talk about phototherapy for thick skin, some pneumatic compression, but I'm not really advocating that. And then some of the more immunomodulators. And like I said, I'm not an expert in all the immunomodulators, but they're out there and they definitely have a role. And then, things that I do, I will do the fusions or arthrodesis, digital sympathectomies. I'll excise calcium. We'll do some skin grafts. We'll drain wounds when they're infected. This is the dreaded one, amputations. But if there's necrosis and the finger has shown no chance of survival, we'll have to do that. And sometimes we'll put implants in patients that need them. So this would be a picture of someone had a really bad ulcer or contracture. So we would fuse that finger, take it out of that contracture. And as you can see, we can get that ulcer pretty much closed. So very common thing we do. This would be someone that underwent an incision and drainage, wound care coverage, and most likely there was calcinosis under there as well. So it got the calcium out. And you can get these wounds to heal pretty easily. Some people ask me all the time about Botox for the hand. It's an off-label usage. I've only found it to reduce pain, but I found it to make sometimes ulcers worse. So I haven't really seen it clinically effective, and I use a ton of Botox for other things. So right now I'm not using it for any scleroderma patients until I could see it more effective. It's an area I really feel like will hold a lot of benefit in the future for scleroderma patients. These non-healing wounds are responding to amniotic placental tissue, which are undifferentiated cells that create beds of nutrients for the skin to grow. Chronic wounds in general are a big problem. And so I've been fortunate, they were very expensive, very hard to get covered by insurance for patients, but this one product right now, the Zenith amniotic membrane, it's placental human tissue, is actually covered by Medicare, surprisingly. And so if there's anyone out there that needs it, this could be a potential option to get it covered. I can't guarantee it, but we can certainly try it. I'm told most patients have no problems with it so far. So if we need to use amniotic tissue for non-healing wound, I am all for it because I think the growth factors in it, and these are all the great growth factors that can help stimulate a wound healing, are way more than skin grafts or anything else that we can do. And it doesn't require a donor site. Now it may be covered. So these are the things that I'm looking forward to for the future, treating patients with scleroderma and non-healing wounds. So as long as it's covered, we don't have issues with that. this is a great way to try to get a wound to heal. And we've seen good results. I've seen great results, and I've been surprised how good some of the wounds have healed with using these amniotic tissue replacements. This is not a finger, but you can see how with serial applications we can get a wound to close. So despite compromised blood flow, there's always capacity to heal skin, soft tissue, and wounds. So we'll always plan surgery to help alleviate pain, prevent loss, improve function, enhance aesthetics, and obviously improve patient satisfaction and self-image. So just find the right doctor for you. I'm here in Houston, Texas. I don't practice anywhere else. But if you can make the trip down here, or we can always do a video consult or something, that's great. Or talk to the foundation, go on the American Society for Surgery of the Hand, talk to other patients and ask what they've had done, their experience, work with the support groups. You could use the internet. Most people do a lot of searching before they get to me. Find a compassionate doctor who has some empathy, which is hard to find these days, and has enough experience to help you out. And it's hard to get someone to come in from out of town and then fly in and fly out, but we do see patients from all over the country. It just makes it a little bit more challenging, but sometimes it's worth it if you can't find someone locally. And then of course there's always the financial consideration. In my office, we try to give patients their benefits and let them know ahead of time what things are. It's not always the case, but we try to be upfront, because I know finances can always be a big rate limiting step. Usually if there is a problem and you just need to talk to someone, we always make some kind of an exception if you just want to do a consultation and talk and get a second opinion. That's always something we can always talk about and make those arrangements. And you just mentioned that you heard Dr. Khorsandi's talk at this, and we really try to accommodate scleroderma patients as best we can. All right, so and then that's my personal information. I know it jumped around a lot, talked a lot about different things today, but hopefully it was a little bit of everything to give you an idea of how we could help you with your hands. So I think that's it.
Well, thank you, Dr. Khorsandi. That was a lot of information that we deeply appreciate. I even saw a couple of my fingers on there.
I know.
But yeah, if there's any patients out there that are interested, here's Dr. Khorsandi's information. We're very fortunate now to have telemed, where you can have online consultation and things like that. So that's very generous of you, Dr. Khorsandi, to offer that. Okay, now I'm going to turn it over to Lily and Renee for questioning. If you have any questions, please list those on the chat. And okay, ladies, take it away. Lily, would you like to go first?
Yes, but we don't have anything right now unless you're seeing something there.
Okay, no, I'm not. I think there was one that I saw that was asking about the products that I was using. We can send those in an email. I got Rosedale information on that. And and Dr. Khorsandi stated too, we don't really endorse certain products. All we can do is tell you what works for us as a patient. And you should always consult your physician with these products before you use them. But again, we can't endorse or anything like that, with products and stuff. So I think there's a question that just popped up, Lily.
No, I don't see one, but I do have a question for him. Dr.
Okay.
Khorsandi, I noticed that there's lines on my fingernails. Is that something that comes with scleroderma, and they're vertical?
Sometimes you could get split nails, but as long as there's no hypopigmentation, it's dark, that sometimes needs to be looked at just to make sure it's nothing serious like melanoma. But split nails are common. We don't really do anything about it unless it's painful. The one thing I haven't also noticed about the patient's distal phalanxes that have scleroderma is over time you can get osteolysis, meaning that bone could almost like disappear, and over time and then you end up not having a distal phalanx anymore, and then that's why you see some patients will have these like little nubby ends of their fingertips, and the nail changes a little bit. It's most likely because they're losing some of that bone underneath. And I'm not really sure why that happens, but I see it quite often. That was a good question.
I see, Renee, do you see any questions? Because I've got two if you don't.
Dr. Khorsandi, Nancy has a question here. She says, I was in a trial for Ilioprost by infusion. It really worked for her renals, and it seemed to improve my hands in general. Is it FDA approved in scleroderma in the States yet, and available for prescription and or insurance coverage?
Yeah, see, I wouldn't know because I don't prescribe it. So I could find out. So yeah. So like I don't do any of the IV infusions. That would be like a Dr. Mays, Dr. Cece kind of and they might, they're always doing different trials. So whether if it's not something you can get, they might have a ongoing trial with that particular drug. So we can find out, and I'll find out if it's available in the U.S. But it's something I don't treat that side of the Raynaud's. Now, what I do, and I'll do a whole lot of it, are digital sympathectomies, and that's like, so we go in and we separate the digital artery from the nerve in the fingers. You could do it in the palm, you could do it in the wrist. And the thought behind that is to increase blood flow to the fingers. And it's great in the short term because you'll get some blood flow, feel great, less pain. But the long term of that is, the disease process continues. And so there's not a whole lot of good studies to show that that's a long-term benefit for patients, but it may help like short term if you're really in a lot of pain and stuff. So I didn't really go into a lot of digital sympathectomies simply because I'm trying to get away from that. I like to do things that are, that will provide some long-term benefit. I hate to put someone through a very long procedure and only get, a couple of years out of it. But it's an option.
Okay, I do have a question. This is coming from Miss Rosedell. Is hyaluronic acid okay for our skin, or should it be avoided?
Well, hyaluronic acid is a naturally occurring substance that you find throughout your entire body, joints, everywhere. It's when it breaks down the water. So I don't necessarily have a problem with using any kind of product that has hyaluronic acid in it.
Great.
Okay, Dr. Khorsandi, I have another question from Karen McClary. She says, my hands swell due to scleroderma. I thought this was my finger split.
I'm sorry.
She says, her hands swell due to scleroderma. She goes, I thought that was why my fingers split.
Okay, I'm not sure what. Do you all know what she's referring to?
I think maybe is she probably talking about the little cuts that we get in our fingers, how they kind of split. I think that's what she's referring to.
Okay, a little like
like paper
splits.
cuts, so to speak. Yeah, I'm assuming that's what she's talking about.
She sent a little bit more here. It says you are saying it is blood flow, possible blood flow problems.
Yeah, it probably is, especially with swelling. It might be that there might be some good flow to the hand, but coming back, the return of venous flow may be diminished, and she's probably getting a lot of swelling or venous congestion, and that's why the fingers are swelling. And anytime you have edema, it will definitely create some open wounds, so, and finger splits.
Okay. I have another question, actually possibly two questions here from Suzette. She goes, I get cuts, the skin breaks in the tip corners of my fingers. Could those cuts lead to ulcers?
Yes, and potentially infection. And the cuts are occurring just, I'm guessing, on their own, spontaneously, or just are they?
She didn't.
They usually do start, Dr. Khorsandi, on their own. It's just, and I know
Yeah,
sometimes the finger swells so much that they cause a split. But sometimes when an ulcer is starting to break out, that's the sensation that we feel. It's like a
right,
razor cut. And then if it's
right,
not watched carefully, then it turns into an open ulcer. So I think those are
right.
the first baby steps, if you
The
will, of an
initial,
ulcer. Yeah,
yeah, the initial present. And like I said, around the nails are very common,
yeah.
because I think the blood flow is definitely diminished in that area. You got a pressure point between the bone and the nail, edema, swelling. So those are some of the first places we see them. Um, and it's a combination of all the things that we've talked about. Pressure, maybe there's underlying calcinosis in the area. Um, diminished blood flow, things like that, and those cuts start to, like you say, that's the beginning of it, and then it doesn't heal, and then it becomes more of an ulcer over time.
She also had one. I have another question from Suzette. She says, I've heard that, I'm sorry, I'm going to probably butcher this. Chelation IV treatments could help circulation. Do you know if this is something that would help?
I don't recommend any type of infusion of that nature, but I don't know. I haven't seen any studies for or against it. So again, I would defer that over to like a Dr. Mays or a Cece. I don't. I kind of just stay in, with the hands, and let them try to manage like the medical stuff, the blood pressure, the IV infusions, and all that. So that's kind of out of my wheelhouse to tell you whether or not. But from what I know, I haven't heard too much favorable things about it. But like I said, I would defer to the medical doctors on that.
I have another question. PRP therapy, Dr. Khorsandi.
Um, well, so PRP is platelet-rich, plasma-rich protein. And when you take it from your own blood, autologous blood, you spin it down. I use it in my practice mostly for healing. There are some growth factors. There, it's better than some things, but you're not going to get as much as you would out of amniotic membrane in terms of growth factors and stuff. There's less. And there's something called exosomes out there too. There's one product that's out there that's made through LSU that has way more growth factors. But if you're on a budget, PRP you might be able to use that to help with wound healing. You can almost make it either in a liquid form or a membranous form, and you can apply it to a wound. However, I don't often do it in my clinic, but it's an option. Anytime you get into stem cells and PRP, there's not enough evidence-based medicine to support any of this. Now, that doesn't mean it doesn't work. It just means that people haven't really done enough studies to really say this is proven. It's kind of like the Wild West out there when it comes to some of those products, but there is potential, and I believe in it. So, but the level of studies aren't there to like fully support it. But I think that that's the trend, and I'm hoping that as time goes on in the next few years, people will do more and more studies to show that PRP, amniotic stem cells, exosomes are showing benefit in many different ways, as they are, like, people are researching all those and many different aspects of our healthcare, whether it's, concussion related injuries from football or wounds or orthopedic issues. So they're trying to apply all that in so many different forms, and I do see that the best benefit, with PRP, with amniotic, has been on wound care, and so out of everything I've done, so that has been promising, at least in my clinic.
Can I would like to share something with you. I
Sure.
have done the PRP therapy with my primary doctor on an ulcer. Um, should I have done it? Probably not, but I did. Um, and it did work for me. I mean, I'm all for research. To me, I think if it helps the scleroderma community, it's a plus. It's a win-win, right?
Yeah, no,
So,
this is
but
what
it
I'm
was a
talking about.
couple of years ago. So,
Yeah,
and
I,
the
I- th-
ulcer never came back.
that's awesome. See, that's what I'm talking about. I mean, the I'm very encouraged as well, and I've seen the same results with some of these treatments, and that's great. And wish we could harness them all together and show
Right,
like a study that improve. And we can do case studies, but a case study isn't as strong as, let's say, we did like a double blind study where you didn't know what I was giving you and I didn't know what I was giving you, and either the wound healed or not, and then we find out of 100 people that we did, the 50 that got the PRP all healed, and the 50 that got the
right.
placebo didn't. So we want to get to those kind of studies, as opposed to like a case study, because that's when really people start to pay attention and insurances will start to approve it. But I'm so happy to hear that from your personal experience, and that's why I don't discourage it, because I think that's the frontier right now.
I agree. I do have a question. This is from Rosedale. A few different types of doctors were mentioned. Other than hand surgeons, what type of doctors do you recommend for us to go to for hand care before things get too bad with our hands? Vascular, dermatologist?
That's a great question. It depends. If you have a focused problem, definitely see that. But I think everyone needs to have a good um, um, primary care doctor or internist that will just specifically manage your scleroderma or has experience in doing so, so that they're aware of all the issues that may come up. So that I think everyone who's experiencing any kind of hand problems should probably see at least get an angiogram or MRA, or see an interventionalist that can do that, just to assess, blood vessels. And if there's an issue that can be if there is potential that a vascular doctor can help you revascularize, and I think that person would refer at that point. Dermatologists are always, good to have on hand if there's no one else locally that they can take a look at a wound or any kind of dermatological manifestations. But I think if you need them, I don't think you need to, you know, go to them on a regular basis unless there's a problem. But I think at the very least, having a good internist that knows and understands scleroderma and can help be like the traffic cop and try to tell you when you need to see the vascular guy, when you need to see the dermatologist, when you need to see a hand specialist. I think it would be is a good way of going about that.
I have one more. I have a question here from Suzette. She wants to know, does thick skin crack more easily?
Uh, it's hard to say. I've seen patients with both thick and thin skin. I don't. I think it's what else is going on around the skin, whether you have thick or thin skin that causes patients to have cracking. So I'm not really certain how to answer that, but I think it depends on what else is going on, other circumstantial issues.
Lily, do you see any more questions? I think there's one from Sarah Nicholson.
I don't see in my box.
Okay. Renee?
No, not currently. You want to go
Okay.
ahead? and see
Yeah.
what-
You want to
I
read
see one
hers?
from- Yeah, Sarah wants to know, Dr. Khorsandi, what about H2O2 for cleaning an ulcer? H2O2 for cleaning an ulcer.
Is that
Mhm.
hydrogen peroxide?
She didn't say, Sarah, is that peroxide, the H2O2?
Or is it the water version of the hydrogen?
I've never heard of it.
Let me
Is
just.
is peroxide a good cleaning agent, Dr. Khorsandi?
I would just dilute it with a little bit of saline is fine with me, especially if you have a wound that might have a little bit of scab or something, can help take a little bit like a bloody scab or something like post-op. If I had someone who had a lot of dry blood around, or I don't find it to be a problem, hydrogen peroxide, but I usually like to dilute it.
The dilute, I'm sorry, I didn't mean to interrupt. Did we go over this one from Rose? Many of the meds to increase blood flow to the hands also reduce BP. Isn't that a conflict?
Well, a lot of you want to try to get more flow to the blood, but there could be problems with. That's why you really need to consult your internist, because that is, like I said, scleroderma patients do tend to run on the low side of blood pressure, and so when you take some of these medicines, it could bottom you out. But the whole idea is to, so that's where it's a catch-22, where you want to get more flow to your extremities because you're having problems there, but have to be very cognizant of your systemic blood pressure. So that is a very challenging aspect of this whole dilemma.
Okay. And there, I have one more from Alyssa that wants to know if there's any particular hand exhale uses that he recommends, exercise or physical therapy.
Yeah, actually, I think trying to keep most of your fingers they only go in one direction, one range of motion, flexion and extension. But what I feel is keeping yourself limber is very important. So weird thing clicked in my head this year. I had a 75-year-old scleroderma patient, and she had very little manifestations in her hand, but she did have one problem. So I asked her, what has she been doing all these years to not have, to only have this problem at this very point of her life? And she said she did a lot of yoga, and yoga to me, is a lot of stretching, a lot of, keeping things, joints and body parts very limber. So again, anecdotal, but I think it kind of speaks to what you need to do to kind of fight this process, is to try to keep your limbs and joints as limber as they can, stretch, move all the joints if you can, assist if you need to. If you see a contraction, maybe use a splint to prevent it from further contracting. It may have limitations. I find warm water, in the mornings and at night can help heat up collagen and make it easier to stretch. So, aqua therapy, hot tub, maybe doing some of those exercises in warmer water might be beneficial. But I definitely think that is key to, again, prevention. Not and when if you can do that, it's very helpful. I know it's hard, and sometimes the disease process is more advanced in certain patients than others, and makes it very hard. It's easier said than done, but I think overall that's the direction you should go.
Okay, thank you, Dr. Khorsandi. Anybody else have a question? Any questions?
I do. I
Okay.
have a question. Dr. Khorsandi, I know you don't like using topical ointment, but there is one. How about Neosporin with lidocaine?
Yeah, I mean that one has if you look at some of the healing rates for those, that's a good one. And I think was a study once that showed that they heal wounds faster, the Neosporin, than other topical antibiotics. So I think about 8 days. So that's fine, and the lidocaine obviously will help ease some of the pain of the ulcer. So, but just be judicious. Like I said, my thing with wounds is the more you wash them out and dilute the bacteria, the weaker you make the bacteria. Therefore, it kind of does it better than just having some antibiotic ointment sitting there all day. But you could probably apply it maybe in between, but definitely continue to wash it out, keep those wounds clean. Change dressings as often as you can, maybe once or twice a day.
I have
Okay.
another question. Nancy wants to know, is there any new info on stem cell injections in the fingers? She says she was in a trial, but that failed.
Yeah, so that's what it's like, the Wild West. And so there's a lot of ongoing trials, but you got to think about why. Like, I try to figure out, why am I using stem cells? What's the purpose? And if I'm not sure why she got the stem cell injections, what was the reason? But I think with the potential, with the growth factors and everything, like I said, I think it helps with wound healing. Joints, I don't think it's going to necessarily help some of the sclerodactyly, because a lot of that process is already so advanced. As far as blood flow, I haven't seen anything where it's helping increase vascularity. So I'm not certain why she got, what was the purpose, but whenever you go into any kind of experimental trials and stuff, look at what the purpose of what are we trying to achieve by doing this, and will have any results been obtained yet or not? And so I think those are the things you need to look at if you're going to sign up for trials, and see, try some of these experimental things. And the same thing with the Botox. I think there's a lot of trials on there, thinking that Botox is going to help, since it does help so many other problems that I treat here in my office. But unfortunately, for ulcers and Raynaud's, I haven't seen benefit. So just be very careful.
There's another question from Jennifer Brown. She wants to know, have you heard of using Viagra for Raynaud's?
Oh yeah, I mean, I think half a year on it already. So
Yeah.
Tadalafil, I think it's great. It works great. Don't worry about the stigma, and it's definitely a good use of the drug. It's providing a lot of help for a lot of patients. So I'm all for that.
Okay. Any other questions, ladies? I see one from Jenny. Is Dr. Khorsandi, what are your thoughts on taping slightly curved fingers at night using athletic tape to help straighten digits?
It might help. I mean, as long as it's not too tight and you're not cutting off any circulation, I think it would probably act as some form of a splint. So if you're finding it's good, not causing any pressure, ulcers, diminished blood flow from taping. Remember, these digital vessels are very fragile, so you don't want to overwrap them or put anything too tight around the finger. So
I got one more question for you. Sarita wants to know, will hand surgery only on the joints below the nail bed cause the entire digit to be immobile?
the entire thing, if you have surgery just right here, I would think there's more going on than that, because if you just had surgery here, it shouldn't affect your PIP or MP joint. Although, unless she was immobilized for an extended period of time, but that should come back with therapy. Again, don't have the specifics on that, but in general, no, shouldn't.
More questions? Lily, do you have any
I
more?
do. The paraffin. What do you think? What are your thoughts on paraffin?
No problem with that. We use it a lot in hand therapy.
Okay.
It's great. Feels good.
Yes.
Yeah.
And zinc.
No problem with that either.
This comes from Rosedale.
Yeah.
Those are great.
Yeah. That's all good.
I have a question, Dr. Khorsandi, that a patient brought to me last night about the paraffin wax. Is there pros and cons about using the paraffin wax machine with open ulcers? I've never done that. I've always waited till they close. What's your take on that?
Well, yeah, I mean, as long as you can get out, I mean, I wouldn't be doing it with an open wound either, because, I think it's good for just maintenance.
Okay.
Those are maintaining. I think if you got an active open wound, you should treat it with caution,
Yeah. Okay. Any other questions, co-host? No? Well, Dr. Khorsandi, we'd like to thank you for your time and taking time out on your Saturday. I know your kids keep you busy and your Saturdays are limited, so we deeply appreciate great questions, great talk. And I just want people to remember that a lot of times, Dr. Khorsandi, patients think that they don't need a hand surgeon. I think a good thing to keep in mind is it doesn't hurt to inquire and ask questions before it gets out of hand. So I think with scleroderma patients, that's very key, is making sure you get to your issues before they really get out of hand.
That's correct. I mean, I would say about probably 70% of patients I talk to with scleroderma, well, you don't operate on. So I guess calling myself a hand surgeon, I should call myself a hand doctor or a hand specialist. I don't want to scare anyone.
Exactly.
We only do surgery when it's necessary. And I just want to say it was a pleasure spending this morning. And I don't have my kids today, so that's great.
No.
So it worked out perfect, and it's always a pleasure. And education is a very important thing. And no one always has all the answers, but like I said, getting together in groups and getting a chance to pick someone's brain is always great. So I'm happy to do this whenever y'all need me. Reach out to me if you want to talk specifically about your own personal hands. And, Debbie's always a great resource, and I know she'll always respond to anyone's questions. She's amazing. So thank you again for this opportunity.
Thank you, Dr. Khorsandi. Thank you so much. And thank you, everybody, for joining us today. I think we, have one quick reminder about Tuesday, November the 29th is Giving Tuesday. for the National Scleroderma Foundation. And so make sure that you let your family know. You can get the information from our website, from the Texas Bubonic chapter, and from the National Scleroderma Foundation chapter as well. And please continue to check out our Facebook page, Twitter, and Instagram for upcoming events with the Texas Bubonic chapter. So co-hosts, thank you, and attendees, thank you for today.